This lecture will be on Chapter 2, from hematopoiesis to the complete blood count. At the end of this lecture, the student will be able to define the components of hematopoiesis with respect to production, development, maturation, and differentiation of the blood cells. Describe the organs used for hematopoiesis throughout fetal and adult life. Describe the four functions of the spleen. Differentiate between intramedullary and extramedullary hematopoiesis, and define the morphological classification of anemias. The student will also be able to list and define the components of the complete blood count, also known as the CBC, calculate red blood cell indices, describe clinical conditions that cause valid shifts in the mean corpuscular volume, or the MCV, and recognize normal and critical values in an automated CBC or complete blood count. The student will also be able to describe the bone marrow response to effective erythropoiesis, as well as define the importance of correlation checks within a CBC. Hematopoiesis is the production, development, differentiation, and maturation of all types of blood cells. There's extramedullary hematopoiesis, which happens within the bone marrow, and there's also intramedullary hematopoiesis, which happens on the outside of the bone marrow. This can happen in the liver or the spleen, and oftentimes it occurs due to issues with the bone marrow being able to produce those blood cells, and it can cause hepatosplenomegaly, which is the enlargement of the liver and the spleen, because it actually puts strain on these organs. Hematopoiesis starts in early fetal development within the yolk sac, which occurs between 2 weeks up to 2 months of age, and this time period is known as the mesoblastic period. It then shifts from the 2-month to the 7-month period of the fetal life, where the hematopoiesis occurs in the spleen, the liver, the thymus, and the lymph nodes. Once the baby develops into the 7th month period in utero, until the birth, the hematopoiesis is going to occur within the bone marrow. So late fetal development into adult life, the primary role of the bone marrow is for hematopoiesis. Then, as we mentioned previously, the liver and spleen can kick in and start doing the hematopoiesis in lieu of issues with the bone marrow, such as leukemia or tumors that are affecting the bone marrow and that production, even though it can put additional stress on those organs in the body. The spleen has 4 major functions. The first one being it is a reservoir, meaning it holds or stores 1/3 of the granulocytes, which are your white blood cells. It works to filtrate the blood and get rid of old or deformed red blood cells. Old meaning once they reach that 120-day lifespan, or any type of inclusions that may be in the red blood cells, such as Hal-Jolly bodies, and those can be recirculated. It also plays a role in the immunity as far as it produces opsonizing antibodies, and these help in the process of phagocytosis, where the antibodies strip the capsule from the bacteria, making it easier for phagocytosis to occur and ridding the body of the bacteria that can potentially cause infection or issue. And lastly, it has the hematopoietic role when it comes to red blood cells, white blood cells, and even platelets. As we've already discussed, it is part of the process from 2 weeks to 2 months, and in utero, and eventually it switches over to your bone marrow. However, it still can be considered a backup if there are any issues with the bone marrow. When it comes to the anatomy and physiology of the spleen, you have different sections of the spleen. You have the red pulp, whose main job is the red blood cell filtration, white pulp, where the lymphocytes are processed, And then you have the marginal zone, which is where the storage of the lymphocytes and platelets occur. Sometimes a splenectomy or removal of the spleen is necessary due to some type of issue with the body, or if you've been in an accident, like let's just say a car accident and the spleen has ruptured. Because the spleen plays such a major role, having that removed can cause issues. Some of those risks can be an overwhelming post-splenectomy infection, or OPSI. You have more of an issue with encapsulated bacteria because the opsonizing antibodies are not released. You also will see more abnormal red blood cells or inclusions in the peripheral blood circulation because the spleen has not filtered those out. The white blood cells and platelets have to find storage elsewhere because they can no longer be stored in the spleen. And oftentimes, when the spleen has to be removed, they try to leave some splenic tissue in place so that it could still do its job to some degree. The bone marrow, which is where the primary hematopoietic process happens once you are past the infant stage that we've talked about, is one of the largest organs of the body. Within that bone marrow, there are two types of marrow. You have your yellow marrow and your red marrow. It's an intricate supply of nutrients and blood vessels, and those that are less than 18 years old. The marrow is spread throughout the major bones, especially the long bones. So you think about the longer bones in the thigh of the leg. Whereas greater than 18 years old, the marrow is replaced by fat, and it's located primarily in the iliac crest, and that's of the hip bone, like the top of the hip bone. We do have an image of that coming up. And also in the sternum, which is the middle of your rib cage, right in the middle of your chest. So the functions of the bone marrow are for, the number one, the supreme factory for production of all adult hematopoietic cells. It also functions as where the cell maturation occurs, and as well as responding to any type of anemia. It will kick in and produce more red blood cells based upon what's happening with the body. With the bone marrow contents, you will see precursor and mature cells in the bone marrow. You can see erythroid cells, myeloid cells, megakaryocytes, which are your platelets, osteoclasts, which are cells that help form or build bones, and it also works to repair any type of damage to the bone. Stroma, which is a cell that builds any type of connective tissue in the body for any organ, any of the organs in the body. And lastly, the bone marrow also contains fatty tissue. One of the ways that changes can occur from the bone marrow is when the body looks at the myeloid-erythroid ratio, which can predict any type of hematologic problem. So a normal ME ratio, or myeloid to erythroid ratio, would be a 3-to-1, so 3 myeloid to 1 erythroid, or 4-to-1. So if that ratio is off, then it can cause erythroid hyperplasia, which means that if there's some sort of anemia that is happening in the body, the anemia stimulates the body to produce more of the erythropoietin, or EPO, and that is to increase the red cell count. So the body is aware that the red count is low, it needs to be increased, and so there is an increase in the immature red blood cells in the circulation of the peripheral blood. And it's abnormal to see these immature red blood cells in the peripheral circulation, and you may also see the more immature nucleated red blood cells, reticulocytes, and even polychromasia, which we'll talk about more later, where there is a variation in the color of the red blood cell. Also within the bone marrow, you have your stem cells and cytokines. Stem cells are pluripotent, meaning that they can produce any type of cell line. So we have the lymphoid precursors, also known as T cells or B cells. We have non-lymphoid cells such as GEM, G-E-M-M, which is your granulocyte, erythroid, your monocyte, and your megakaryocyte. The cytokines are responsible for stimulating the bone marrow and determining which lineage that's going to be produced. And the EPO, or erythropoietin, is what stimulates the red blood cell production. So the erythropoietin, or EPO, is a cytokine. It's a hormone that is produced by our kidneys. It stimulates the red blood cell production, and it also can be found as a pharmaceutical product known as human recombinant erythropoietin that can be used if needed for particular patients. When a patient is having various issues and a doctor or pathologist wants to do a bone marrow aspirate to determine what is actually happening within that patient's bone marrow, they will do a bone marrow procedure, a bone marrow aspirate, which is very invasive and it is potentially painful procedure. I have witnessed bedside this, and it is hard to watch a patient go through it. Oftentimes, as a technologist, you will be an assistant because the pathologist wants the slides made immediately once the aspirate has been obtained. The technologist reviews the smear and determines if the aspirate is an acceptable specimen. I haven't found this exactly to be true. Normally we're there at bedside to make sure the slides are pushed, and then those are stained and given to the pathologist to review. Now, we might be able to review if it was a good push or not, just like we do with peripheral blood, but ultimately it's the pathologist that will review it for determination of what is happening with that patient. The site of choice for the bone marrow aspirate is the iliac crest, as I mentioned earlier. It's at the top part of the hip. We do have a picture coming up that will show you that. They do give the patient a local anesthetic to kind of numb the area. Once the needle has been seated into the marrow, the syringe is placed on the end. It's kind of a corkscrew looking device that they use. A small amount of bloody fluid is obtained. The technologist locates the spicules from the specimen, and the biopsy may be taken at this time as well. They kind of corkscrew it in by pressure into that iliac crest to obtain what they need, and as I mentioned previously, to push those slides so they can see what is actually happening inside of that patient's bone marrow. Here you can see the iliac crest, the top of the hip bone. This shows an aspiration needle. This particular style I'm not as familiar with. However, I'm sure it serves its purpose. So the needle is actually pushed into the bone by pressure and is extracted in order to push those slides and make it more evident what is happening or not happening within the patient's bone marrow. Once those slides are prepared, the physician or the pathologist will evaluate the bone marrow for several different things. The overall cellularity of the smear, the ME ratio, they're going to look at 300 to 500 cells, the maturation of each cell line, the marrow to fat ratio, the presence of abnormal or tumor cells, and they may also use the Prussian blue stain where they can evaluate any type of iron stores that are occurring within the bone marrow. Now, outside of a bone marrow aspirate evaluation, the more commonly used lab work that is ran potentially on most patients is a complete blood count. So a complete blood count includes a total white blood cell count, a total red blood cell count, hemoglobin, hematocrit, mean corpuscular volume, or MCV, mean corpuscular hemoglobin, or MCH, mean corpuscular hemoglobin content, MCHC, your total platelet count, and your red cell distribution width, which is your RDW. A complete blood count, or CBC, is usually collected in an EDTA, anticoagulated sample. Typically that's going to be your purple or lavender top tubes. There's going to be a direct reading on your automated instruments of your white blood cell count, red blood cell count, your hemoglobin, and your MCV. The hematocrit, some of the others are actually indices, which means they're calculated. They're not a direct quantification. There are also some correlation checks that we learn to make sure everything jives on a CBC, which is a significant part of the quality assurance, which is the rule of 3. So your red blood cell count is multiplied by 3, and that should equal your hemoglobin. And your hemoglobin multiplied by 3 should equal your hematocrit. So that's like a verification, very simple calculation that you do to make sure everything lines up as it should. And we'll talk later more about if this doesn't line up, what are the reasons why, and how do you handle it, how do you troubleshoot it. So in the hematology department of the laboratory, we have automated instruments that will present a pictorial representation of the data registered as either a histogram or a scatter plot. We'll talk more about that. Most instruments also offer automated reticulocyte counts as well, which is the immature state of a red blood cell. This is a chart that kind of gives you an overview of different types of anemia as to how it may present, as far as how the red blood cells look and what the MCV or MCHC may be. So the top one, you have normocytic, normochromic. Norm meaning it's a normal, and cytic meaning cell, normal size, and then normochromic meaning normal color. Microcytic meaning the red blood cell is smaller than normal, and hypochromic meaning it has less color than what it should. As well as macrocytic meaning the red blood cells are larger than what they should be, however they have a normal color. So this gives you the ranges for the MCV for those, and as well as the MCHC. So we're going to talk about some of the things that you see on the CBC that are actually calculated. So the first one we're going to talk about is the mean corpuscular value, or MCV. It's one of the most stable parameters in the CBC. It evaluates pre-analytical and analytical specimen integrity. The MCV is the hematocrit divided by the red blood cell multiplied by 10. So the reference range for MCV is 80 to 100 femtoliters. The red cell size of 6 to 8 micrometers, which is a normal red blood cell size, 6 to 8 micrometers. If you have any type of shift in the MCV, it's usually caused by cold agglutinins, transfusion therapy, or reticulocytosis. A pre-analytical changes in the MCV can be caused by IV contamination, meaning that you have a patient on the floor, the blood has been drawn, and they did not properly obtain that specimen, and so the IV fluids has mixed and contaminated the specimen. Specimens that are from hyperglycemic patients, which means hyper means high or increased glycemic, indicative of glucose, so that means that the patient is diabetic in some capacity. And also you can have changes occur when the patients are on some sort of chemotherapy drug. The MCH and the MCHC, so we have mean corpuscular hemoglobin as well as mean corpuscular hemoglobin content, and they both provide information concerning the red cell hemoglobinization. So the MCH is the hemoglobin divided by the red blood cells multiplied by 10, which gives an average weight of the hemoglobin, and the normal reference range for that is 27 to 29 picograms. The MCHC is the hemoglobin divided by the hematocrit multiplied by 100, which gives you the amount of hemoglobin per red blood cell as a percentage. So the reference range for your MCHD is going to be 32% to 36%. We saw that in the chart previously in regards to types of anemia. We also have our RDW, or red cell distribution width, which is a mathematical calculation. So when you have anisocytosis, which means there's a variation in the size of your red blood cells, as well as poikilocytosis, which is a variation in the shape of the red blood cells in the peripheral blood, it will cause the RDW to be off. So the RDW is the standard deviation of red blood cell volume divided by the mean MCV multiplied by 100. So the reference range for the RDW is going to be 11.5% to 14.5%. When it comes to your job as a tech, when you're evaluating your CBC, obviously the instrumentation does the bulk of the job, but you are there to have eyes on to make sure everything jobs. That's why we learn about the rule of 3 and other calculations to verify this, as well as if a manual differential, which we have not gotten into yet, is warranted. But even so, with the automation, it will let you know when you have a critical value. That means it's the patient's results are not just high or low, but they're at a critical stage that needs to be addressed immediately. Let's say you have a 8-gram hemoglobin. The patient is going to be in obvious distress, have problems with breathing, and they need to determine what is causing the hemoglobin to have gotten to that low of a level. So critical values are values that are outside of the reference range, and they need immediate notification to the physician or the nurse. So if you were to see that a patient has an 8-gram hemoglobin, you would call the floor, let the nurse know. Sometimes you do talk directly to a physician. And also, if you have not heard this in any other class, when you have to contact a doctor or a nurse, this has to be documented. If you did not document it, it did not happen. And this is not going to fare well for you, because it's going to look like you didn't notify who needed to be notified. So bear that in mind going forward. Proper documentation of notification of critical values to the floor should be made. So the full name, the date and time, who you spoke with. I spoke with Nurse Sally at 15:15. And I let her know that this patient had an 8-gram hemoglobin, etc. Here's a graph of some examples of critical values, and this may vary from site to site. So you have your WBC, or your white blood cell count. If it's lower than 3 or greater than 25, it would be considered critical. Hemoglobin, this chart recommends anything 7, which I mentioned 8. And higher than 19. Platelets at 20,000 or higher than 1,000, which is multiplied by 10 to the 9th per liter. Here's another chart that shows CBC reference ranges based upon the age or even the sex of the patient. There is a little bit of variation when it comes to your red blood cell count and hemoglobin count between an adult male and an adult female. Most of the other ones are, there's just a little bit of variation with those. There's going to be a bigger variation with a newborn and an adult, and then slight variations with a male and female patient. Anemia occurs when there's a reduction in your hemoglobin, so that you start to have physical symptoms of that. The hemoglobin, any hemoglobin level that's below 7 grams per deciliter may cause particular symptoms such as vertigo, which is dizziness, pallor, meaning you would have a paler color to your skin, fatigue, tachycardia, which is a type of arrhythmia with your heart, syncope, which is fainting spells, and hypotension, meaning low blood pressure. So these last two slides are key equations that we've already discussed for MCV, MCH, MCHC. Your correlation check, like we discussed with the rule of three, as well as key terms such as hematopoiesis, erythroid hyperplasia, erythropoietin, EPO, hepatosplenomegaly, which means enlarged liver and spleen, and your myeloid to erythroid ratio. So make sure you guys know those terms going forward.